I hope everyone's doing well. I'm so happy to talk to you today about cannabis and geriatric care. A little bit about myself. My name is Gloria. I've been an RN for almost 15 years now. I got my ANA board certification in gerontology. Wasn't sure that I was going to be a specialist in this field, but here I am. I feel like we all kind of touch base into that, gerontology area a little bit, unless we're in pediatrics or something specific. Geriatric patients are kind of involved in all of our work to some degree. I got my cannabis experience started with working with multiple sclerosis patients for 10 years, was not a cannabis user at that time, and I learned a lot. I also have had some experience in insurance work and 20 years as an EMT. That's really sad to count. But currently, I took a new role as the medical supports coordinator for Delta Community Supports. Totally different group of individuals, but it's community-based living for those who have intellectual and developmental disabilities. We're getting cannabis into this space, so I'm really excited to eventually introduce that to you at some point. So let's start talking about what our geriatric patient brings as risks and considerations when we're trying to dose them with cannabis medicine. Geriatric patients are a little bit difficult when in comparison to the normal or the average cannabis patient. They tend to be a little bit what I like to call medically content, meaning that they're not the average patient to seek out new treatments. They're not reading journals and looking at the most cutting edge research. They also have little access to educated providers. Gerontologists in general are a small group of practitioners. And then within that group, we all know there's very little cannabis and endocannabinoid system education with those providers. So access is extremely limited. Social barriers are in existence for patients of all ages, but particularly for our geriatric community, because cannabis medicine can be so expensive. There's massive financial restrictions when you're on a fixed income. And they are very subject to longstanding stigmas and biases. So they grew up in a time where cannabis was very taboo. And when we're talking about actually dosing the patient, when we've gotten the information and the medication to the patient, how do we manage what we give the patient that takes in consideration their geriatric risks? So we know as we age, we reduce sensory function, visual, and hearing. Everything decreases, or it has the potential to decrease. So we need to take that in consideration when we're dosing our patients. We know these are important patients to start low and increase slowly. The unique piece that cannabis medicine has is the psychoactive impairment. We have the choice whether or not we want to involve that in the care of the patient or not. And in geriatric patients, that is a unique ability to be able to control, because when we are talking about chemovar selection and balancing THC and CBD, we can manage the risk of psychoactive impairment for those geriatric patients who are at risk, who may have cognitive decline or confusion already. And finally, we also talk about the reduced metabolism of the patient. Geriatric patients are in need of alternate dosing options other than ingestion of medication. This is due to reductions in the metabolic processes, particularly the first pass process, where if it's interfered with geriatric patients, we can actually end up with higher concentrations of drug in circulation than we want to. So taking into consideration these risks that geriatric patients present, let's talk first about chemovar selection. This is an adapted chart from Dr. Uwe Bleshing's Cannabis Health Index, and we're talking specifically about cognitive change potential here. So the management of the balance between the ratio of THC to CBD is very relevant for the geriatric patient. We're talking about when we need to lower the amount of cognitive change potential. But you'll see as we talk a little bit further that there are some benefits to having that THC heavy ratio when it comes to dementias and neuropsychiatric symptoms, as we talk about here, as well as chronic pain. When we're talking about reducing medication harm for the geriatric patient, it's not just polypharmacy that we're talking about, but more inclusive as a term is the geriatric syndrome. So instead of just talking about polypharmacy and how that might affect our geriatrics, we need to also talk about how geriatric patients handle side effects. Multiple side effects are extremely confusing for geriatric patients, and unpredictable side effects are really hard to manage in our geriatric community. Beyond that, geriatric patients have less psychological reserve when it comes to managing these challenges. So, when we're talking about psychological reserve, we're talking about the ability of the geriatric patient to deal with complications that might negatively affect their financial situation, their social support, maybe if someone doesn't agree with their choice, their mood, their just ability to be functional. So, that less reserve does need to be taken into consideration. We already talked about the changes in the pharmacokinetics. So let's talk now about how we use our dosing strategies a little bit beyond chemovar selection in order to get the best outcomes with our geriatric patient. One more thing that we need to talk about is that dysphagia is a really big concern when it comes to our geriatric patients. It's common. It's in about a third of our older adults. It's usually progressive. It's something that all of us may have a touch of as we get older. So these alternative dosing options are so beneficial for our geriatric patients who are dealing with dysphagia and swallowing changes. Aspiration pneumonia can land you in the hospital for the rest of your life. And if you deal with geriatric patients, you know they say some of their pills feel this big to swallow. So having that option of the tincture, the suppository, lotions, and even nebulizers coming out, these emulsions and nanoemulsions are giving our geriatric patients and all patients across the age groups various options to be able to take drugs safely. Geriatric fall risk is something that we can't skip over when we're talking about deciding on medical therapy for our patients. 1 in 4 over age 65 fall every year, and that is a massive number. For that patient over 65, falls are the leading cause of injury and death. So this is something that we really need to tease apart and talk about individual fall risk and how we can avoid worsening that fall risk when we're talking about dosing cannabis medicine. Splitting apart our fall assessment and our fall risk categories helps us identify where we need to use dosing strategies in order to keep the patient the safest. So a lot of times we're talking about perceptual versus physiological risk. So physiological risk makes a lot of sense. It's the physiological risk, the physiological processes that are causing the person to be more of a fall risk, like gait imbalance or disturbances, imbalance in general, musculoskeletal problems like shaking, tremors. But perceptual risk is something we don't always talk about. Older adults tend to have lower perceptual risk when it comes to fall risk, and that's why they tend to be a fall risk. They're not afraid to fall. They don't know that they're at a higher risk in falling. So cannabis medicine fits right into this sort of treatment because we can avoid adding physiological risk a lot more concisely than we can with today's medications that are available pharmaceutically. So let's talk about some disorders and comorbidities that affect the geriatric population where cannabis can be extremely helpful. Chronic pain is one of the things that I like to talk most about in the geriatric community because we really are trying to avoid opioid use in the geriatric community. Opioid use for geriatrics is extremely dangerous. We are very familiar with the nausea, vomiting, but constipation is huge and can lead to small bowel obstructions in the older population. Also, we're familiar with the fact that opioid use runs that danger of respiratory depression. So when we replace the opioids with cannabis for pain management, we get treatment that's based directly in the endocannabinoid system, which is often what is regulating the pain. And also, it's just well tolerated. So there's a lower instance of these side effects. We don't run into these risks when it comes to most cannabis medicine. We can mitigate the risks when we do use cannabis medicine. There's low side effects and there is a low potential of abuse, which we know is not the case in the case of the opioids. Speaking a little bit about cardiac disease, the jury is still out. There's a lot of research that still needs to be done, but cardiac disease is extremely common in older adults. More than 20% of older adults suffer from some sort of a cardiac disease. whether it's CHF, CAD, hypertension. So it does warrant a discussion. THC or chemovars that are higher in THC do run the risk. THC use does run the risk of causing adverse cardiovascular events through tachycardia or dysrhythmia. So it is a risk that we do need to mitigate again. And another is looking at cannabis's role with platelet aggregation and clotting. So a little alert about cannabis and dual antiplatelet therapy, or DAPT, which is what we're currently using for acute coronary syndrome. So in America today, an adult who has an MI, acute coronary syndrome, goes home on DAPT, which is a P2Y12 inhibitor, usually clopidogrel or Brilinta, and aspirin for a year. And that will help with platelet aggregation going forward and lower the risk of a clot. There is an unsure correlation with cannabis, and it could cause subtherapeutic levels of antiplatelets. So we're talking about like Brilinta, for example. There's concern to show that high concentration of cannabinoids platelets will aggregate to synthesize that THC. So somebody with acute coronary syndrome would really need to watch that with their cardiologist. Moving on to dementias and neuropsychiatric symptoms, one of my favorite things to talk about, something that I'm currently managing with a lot of geriatric patients, are these neuropsychiatric symptoms that we all have dealt with throughout our entire nursing career. Dementias that come along with agitation, depression, insomnia, hallucinations. Cannabis, particularly high concentrations of THC, is working really, really well for controlling these symptoms. Current pharmacological management is addition of antipsychotics, sedatives, and hypnotics. And a lot of these run the risk of increased fall risk, which kind of defeats the purpose of what we're trying to do for our geriatric patient. So again, cannabis as a treatment, low incidence of side effects, maybe some diarrhea and some somnolence, but it's more predictable and we can manage that. CBD and higher concentrations of CBD has the least incidences of side effects and the lowest abuse potential. And finally, just rounding it all out, we have to talk a little bit about COPD, my favorite. One of the studies that came out in 2022, one of my favorites, neither current nor chronic cannabis users were negatively affected when they were hospitalized if they already had COPD. And cannabis use was not linked to causing COPD for patients. So not only is it not causing COPD, but it's improving outcomes for patients with COPD and helping them get out of the hospital faster. So moral of the story, we got to get this information to our gerontologists and out to our patients.